Let's get real. Let's get loud. On America Out Loud Talk Radio. This is a McCullough Report and Focal Points Substack. It's my great pleasure to welcome to the program for the first time Dr. Henry Barnum. He's a surgeon. He's an otolaryngologist. There's an ear, nose, and throat specialist. And he's going to present a recent paper that's just hit the preprint server. So many of you are going to want to hear about his research and the results and the implications. And so, again, it's a great pleasure. Dr. Barnum, welcome to the program.
Thank you so much for having me, and thank you, for sharing information. It's an honor.
It's a great way to do it, and you've chosen a great vehicle that is the preprint server. But let's learn a little bit about you first. Where did you grow up and go to school and get your training?
Yes, sir. So I'm originally from Louisiana. So I came to LSU for undergrad and then LSU for medical school. And then I moved to Denver. So I was at the University of Colorado for otolaryngology or ear, nose, and throat residency, and then moved to Sydney, Australia for a rhinology fellowship.
Wow.
And then after that, came back to Louisiana, where we were from, and started a practice here in Baton Rouge. And so, yeah, my family lives here. So we have 5 kids here in Baton Rouge, but have a practice that's just dedicated to rhinology, which is a subset of ear, nose, and throat, really specializing in diseases of like just the nose, sinus, and skull base. And then do a good bit of research on diseases associated with that field. So, inflammatory diseases of the nose and sinus, and then taste and smell research. And so that's kind of how we got into this in the first place.
Wow, that's so fascinating. So rhinology is a subdivision of ear, nose, and throat. That's so fascinating. Well, the nose really matters, and all of us have a sense of smell, and we have nasal secretions and hair in our nose, in our nares, that serve various functions. In animals, as sometimes even have more complex noses, like dogs and certain other animals. It is
Yeah,
fascinating.
it is. I'm completely biased, but I love what I do. I think the nose is fascinating. Going into it, I don't know that I would have chosen the nose as what I would say is kind of the coolest part of medicine, but I do think it is such a fascinating area of research, but also just clinical application.
Is it true that dogs, uh, have many-fold greater sense of smell than humans? Is that
Yeah,
true?
I mean, it's certainly, the idea that was around for a long time. It's a little bit been debunked recently by some great researchers, some at Stanford who had evaluated basically blind humans who did this kind of smell test, training to see if they could track as well as dogs. And it does look like the human nose is actually able to perceive, quite a bit, not necessarily, in the magnitude less than what we previously thought compared to
Oh, wow.
dogs.
That's pretty neat. I recently took a safari in Africa, and our guides, we are noticing that the wildebeests, they kind of co-herd with zebras. I
Okay.
never thought about this before, but why would wildebeest they don't breed, but why do they hang out together? And the guide explained that the wildebeest, they have a pretty good sense of smell, but the sight isn't too good. And the
Okay.
zebras have good sight, but their smell isn't so great. So they
That's
complement each
fantastic.
other. Yeah, they complement each other in terms of, detection of threats. Their major threats are basically lions, hyenas, and
So
leopards and cheetahs. So,
that's really fascinating. Yeah.
yeah, isn't that something else? Okay, so the SARS-CoV-2 pandemic hits, and one of the first things that people notice is they lose their sense of taste and smell. Did you see this in your practice? Is this unique to this virus, or is it common to any viral infection?
Yeah, I mean, we had seen it obviously not on the magnitude we did with COVID, but had seen it with other upper respiratory infections. There's some that can obviously, a lot of people when they have an upper respiratory infection, they'll just have nasal congestion or swelling of the lining of their nasal passages, and that can cause more of like a conductive or loss where you just are not transmitting the particles to where they need to go for you to perceive them. But then, there are some viruses that cause alteration, like of the neural process or the neural transmission, and that looked like to be, a big part of COVID, why it was such more prevalent than other upper respiratory viruses. So yeah, saw tons of it. And as I'd mentioned, we do a fair bit of research and some specifically on T2Rs, which are bitter taste receptors. And as you had mentioned, in the animal model, that they're quite fascinating, because they certainly influence taste and preference for taste. But they're a bit more complicated than that, in that we have them throughout our airway. We have them, in the gut. They've been discovered in a lot of different places in the body, and they serve different function than just taste perception. So, they actually are part of your innate immune system and have been shown previously to influence and then, show some predictability in people's outcome to upper respiratory infections. And so that's some of the initial studies that we did in COVID. Um, and published those. And so that's kind of where this study started, is because of prior research on T2Rs as they related to SARS-CoV-2. Um, we got a lot of referrals
Mhm.
for evaluation of people who, physicians and practices who knew that we were doing research on COVID, and then they had these patients who were struggling long term, and so they said, "But look, I know this place is doing some research on this, and they
Mhm.
certainly specialize in taste and smell." And so that was kind of how we got these patients in the first place.
That's fascinating. Let me ask you a question. If the tongue is completely normal, but the ability to smell is knocked out, either via receptors or the olfactory nerve, does the ability to smell, does it directly influence the ability to taste?
Yes, sir. So it's a little more complicated, and this was a great point in COVID, because we would have tons of people who were referred for loss of smell and taste. And there are ways of actually measuring smell and
Mhm.
taste. Um,
Mhm.
and what appeared, this is not true in all cases, because there were cases where both smell and taste were diminished. But in my experience, what most of the data showed was that people, when they lost their sense of smell, what happens is you really lose the flavor. And so you can still perceive the basic taste of, sweet, salt, bitter, umami, um, and
Hmm.
sour. But when you lose your sense of smell, that retronasal smell is really what contributes to flavor perception. And so people would say that their smell was diminished or gone, but their taste was really blunted. They were still able to perceive a lot of salty things or bitter things, albeit, it did change in a lot of people, but most commonly their smell was what was really affected more so than their actual taste.
Now, did the data show that it was unique to SARS-CoV-2 in terms of either severity of this loss or the duration of effect?
In our data, it has, and there are variable reports depending on who you read, but we've kept a lot of logs of a lot of patients. Obviously, that's part of the translational research or the clinical research that we do, is just trying to manage these people and trying to follow trends and see what the population's doing, and then you can help direct management options for them. But I've been in practice for 10 years, which I feel like is not very long. But in my practice, obviously, I have not seen another upper respiratory virus cause the type of sensory changes that we've seen with this one.
Hmm.
That's
Now,
taste and smell primarily.
what's the longest duration you've seen somebody who got documented COVID and they didn't come back to normal in terms of taste and smell? What's the longest duration?
Yeah, it's a hard question because we have a whole host of people who I mean, I still have a clinical practice, and so I still see people, and I'm still seeing people today that have tried different things, and whether home remedies or true
Mm.
protocols, but I still get referred people today who haven't it's either I do have some that I've seen recently who have essentially no sense of smell, and on measurements are listed as complete anosmia.
Wow.
um, but we are implementing ways for them to be able to regain that, and protocols that they can do. And we've had some nice success with that. And so hopefully this is not, a sustained thing longer. I feel like 5 years is long enough, but but hopefully we'll, continue to be able to help.
But let me ask you, do you think someone can go 5 years and they lose their the taste and smell that long?
Certainly, I think the bigger question is, if they have lost it for 5 years, how difficult is it? Is there a chance of recovery? And that's really what, we're exploring. Early in COVID, yeah, I mean, when people had anosmia, they appeared to either get it back, or it would come back somewhat, not fully to what it was before. And a lot of people would report alterations, and things smell different. They get a
Mhm.
chemical smell, or they're not able to smell natural things. So they say that they can still smell cologne and cleaning things, but not, a true rose, or certain foods that are cooked, they usually can. But it's been a real problem, for a lot of patients. And that's part of why we do research, is trying to find a way to help these people.
You're going to think this is pretty hokey, but when I got COVID in 2020, that's before the vaccines. It was kind of more the original versions of COVID.
Sure.
I did have this kind of intense nasal congestion, and I felt ill. And I did notice a change in my kind of nasal sensory perception. And I told my wife, I feel like I'm smelling China, because I had been to China 5 times. And the last time I went, I was in Xi'an. I was in the center of the country. And I was there about the same time I think Mark Zuckerberg was there. And
Okay.
several years ago. And so I went out jogging, I'll never forget. And it was so polluted. I was kind of jogging through this cloud of like burnt rubber smoke. And it almost made me feel sick. I got back to my hotel room. I thought, boy, that was not a smart thing to do. But I almost felt like I smelled burned rubber, or just something that was kind of noxious when I had SARS-CoV-2. But
Yeah,
at that time, we didn't know it directly came out of the lab in Wuhan, China, but it was ultimately determined.
that's pretty wild that you made that association. And it is that, it's been, but I don't want to say that anything good has come from COVID, but in terms of research and being able to, you know, try things to help people, has been a somewhat rewarding, because it is such a fascinating area of research.
Mhm.
Because I mean, being a novel virus, I hope that we don't see another one in our lifetime. But what a, I mean, a wild time, to do both clinical, basic science, and translational research. Because I mean, these are problems that no one has ever experienced before. You can't, if it's a novel virus. And that's sort of, that's sort of why we had the idea in the first place, when we were studying T2R, or how it relates to innate immune response. Because the idea was that any variability in someone's outcome to COVID had to be related either to viral load, so, amount of virus that they were infected with, versus their innate immune response to it. Because you couldn't have an adaptive immune response if you never either had the vaccine, or if you never had, COVID.
Hmm.
Because prior infection or vaccination, the point, what we'll talk about is an antibody response, or an adaptive immune response. But prior to, with a novel virus, and prior to the onset of any measures to influence the adaptive immune system, you're only relying on your innate immune system. And that's part of where, we had studied these receptors in the respiratory tract, and why it was just such an exciting time to study that. I'll say that's about the only thing that has been exciting, or positive about COVID over the last 5 years, in my mind.
Well, just so our listeners can understand, the innate immune system is the individual cell's ability to kind of fight off an invader through
Yeah,
various.
it's like your initial barrier of defense
Yeah,
before it hits your bloodstream, before you
right.
can mount a response with antibodies, or different parts, in your adaptive immune
Th-
system.
Yeah. So the adaptive immune system are white blood cells and those lineages, cytokines, antibodies, and complement. Typically 4 components. But the innate immune system, actually, I'm in Dallas. I graduated from UT Southwestern. Dr. Butler is one of our faculty. He won the Nobel Prize actually on
Right.
toll-like receptors. I
Yes,
have one
sir.
more question before we get into the study at hand. And one of my great pleasures every day is drinking a cup of coffee. I
Yep.
really, there's sometimes I go to bed at night and I'm actually thinking about how good the cup of coffee is going to be the next day. So it's like
Yeah.
really important to me. And every so often I'm traveling and with my wife and we'll go to a coffee place and they immediately put a plastic cap on the coffee. And my wife always keeps it on. And the first thing I do is I take off that cap and I want to smell the coffee. I want to drink the coffee as I smell it. And she goes, "You're going to spill it." I said, "You know what? It's worth it because I want to fully enjoy the coffee." Am I crazy, or do
No,
you enjoy things more if your nose and you're right there?
without question. Hats off to you for doing that. Yeah, no, you look at like wine enthusiasts or people. I mean, part of the reason that wine is delivered in that cup or that vessel is to improve the delivery of the aromas, the smell
Oh,
prior
okay.
to it. Like Fred Minnick is in my mind a great critic when it comes to bourbon, and I use these analogies just because he's done a really great job of describing. Taste as it translates to bourbon, and he always goes into the importance of smelling it prior to. But because the question that you asked earlier of how much does smell influence taste, it is. I mean, it is such a important component, both anteriorly when we breathe in, so that you're priming your senses, so that you're smelling all of the components before it ever touches your tongue, and then
Hmm.
you get the retronasal smell, and that's really where flavor comes in. So yes, it is an important point. Admittedly, you asked the wrong person, because I think
You
it's
know,
fascinating,
well,
but keep
I have
doing it. I would say
Yeah,
that.
I have one other anecdote. This is a fun one. Is I took a trip to Scotland one time and I brought my dad. My dad drinks alcohol, and I don't drink a drop of alcohol. And sure enough, we got involved in a whiskey blending contest.
Okay.
And so we are around a table, about 15 people, and there's this master person who's teaching us how whiskey is blended. And then we're actually making our own blend. And then it's going to be submitted to some people in a back room who are whiskey experts, and there's going to be a
Sure.
winner. So I thought I'm greatly disadvantaged because, and I'm really strict about it. I don't touch a drop of alcohol. So I'm not going to be able to taste my creation. I could only go by smell.
Yeah.
And whereas everyone else around, including my dad, they were smelling and drinking, and maybe that did influence the outcome. Anyhow, we each submitted our samples to the expert panel, and then they announced the winner, and it was me.
Love it.
So
That's
I won.
fantastic.
I won a whiskey blending contest based on smell alone.
Yeah, no, I mean, it is fascinating. Like I don't drink a ton, but I think that smell and taste is just so fascinating, and it's such an integral part of our lives. It honestly is what makes us human. If you look at like taste and taste receptors, there is no animal in the wild that would intentionally eat something that's bitter, because you're going to perceive it as a poison, and you're going to have that noxious response and turn away, and you don't want to take on a pathogen. But we as humans, in the same way that we like to jump out of perfectly good airplanes, we like to live on the edge. And so we drink these incredibly, bitter things like coffee and bourbon. Now, granted, we have learned this associated gain of the mental clarity and high and the relaxation with bourbon. But how fascinating when the way bourbon's made, you have this mash bill of the different components, but then it has to be aged in a new American oak barrel, and all of those components from the tannins in this oak is just a fascinating
Wow.
um, integration of all of this and the science of it. I love it. So
Man, I tell you what, if when you retire from surgery, you could probably be a consultant to the coffee industry or the wine industry. But
I
you
don't know if
kind
they'd
of,
have me, but
but Dr. Barnum, you got into my area of interest with this paper, and so let's bring it up on the screen so
sure.
people can see it. Let me see if I can't bring it up here. There we go. And you can see the title of the paper, SARS-CoV-2 Semi-Quantitative Total Antibody Correlates with Symptoms of Long COVID in both vaccinated and unvaccinated subjects. So tell us about the paper. What was the concept here?
Yes, sir. So, I mean, in short, as we talked about earlier, I and referred a lot of patients with concern for COVID or long COVID just because of some of the prior studies that we published. Um, and admittedly, I was a little bit hesitant, or I don't want to say annoyed, but I didn't love the term long COVID because maybe it's the simplicity on my part and my own inadequacies, but it didn't really make sense because it seemed to be kind of a catch-all, and I know that these people are struggling, but it included such a wide array of symptoms, and so I was referred a lot of people for when they show up in your clinic and it says what's the reason for there, and it would say long COVID. But the issue became, a lot of these people were struggling with fatigue or brain fog or headaches or GI discomfort or chest pain. And I'm a rhinologist. And so, there was a lot of it where I was like, I don't really treat, abdominal
Mhm.
stuff. I don't do cardiac stuff. I'll leave that to you. Yeah. And so it was, but the people were still struggling. And so I finally kind of checked myself and said, okay, take a step back. If I were to define long COVID, and I'm not talking about like what the definitions are of like greater than 3 months of sustained symptoms or
Mhm.
worsening symptoms, but what should that mean scientifically? So, you know, if it's from infection, if it's from vaccination, I don't really care, but I do want to know, like, is there something tangible that you can measure? Is there something objective? Um, and then does that correlate with symptoms? That was kind of the idea behind the study. And so basically all we did was we set it up and said, we're just going to take the first, of the next, once we started it, the next 100 people with a diagnosis of long COVID, whoever diagnosed them with that, that's fine. But if they're showing up for long COVID, we're just going to measure, ask them a history. What are your symptoms? Who
Mhm.
all have you seen? What physicians have you seen? And then, measure their spike protein antibody. So semi-quantitative antibody through LabCorp was an easy one. It's one that we had been using. And there's other ones that you can do. So, there's whether it's measuring nucleocapsid, like that. I wanted something just standard where it doesn't matter what it's from, whether it infection or not, does it correlate with symptoms? Um,
And well,
and
there's a couple possibilities here that the antibody is a reflection of, spike exposure or potentially even continued spike mass in the body, stimulating the B cells and the plasma cells to make more antibody. Another possibility is that the antibodies themselves are part of the pathogenesis of the syndrome.
yes, sir.
Yeah.
That's precisely what we did, and we admittedly had some exclusion criteria because we wanted to make it kind of a clean playing field, if you will. So, like, if people were either diagnosed with immunocompromised diseases or if they were immunosuppression medications, they were excluded because the theory there is that they're not going to make antibodies, and so may not be representative of the general
Right.
population.
Mhm.
Um, and so, clinically, because I'm a rhinologist, I think that my cohort of patients did trend towards more otolaryngology problems, which makes sense because the bulk of them,
Mhm.
that's who they were seeing. And so, over the last probably year or two, I've noticed increasing. I'll give you an example. So, patients who show up with recurrent infections, and so it's like they'll come with a sinus infection, and this happens in the population, but typically sinusitis, the understanding is like true chronic sinusitis. That's an inflammatory condition, analogous with asthma, but in your perinasal sinus cavity. And so, that's a sustained chronic condition that's managed with anti-inflammatories, typically topical, whether it be, topical steroid spray or saline irrigations impregnated with a steroid. And the mainstay of, where surgery has a role in that patient is really to open the sinuses so they can deliver topical therapies to better manage this disease. There are a subset of patients who get recurrent infections. Now, first thing you got to check for is to make sure that they're not immunocompromised, is
Mhm.
why they're getting recurrent infections. But I used to, I don't know if it's my practice or, what, but I didn't. I didn't have as many people with pneumococcal deficiencies as I do today. And so I felt like I was seeing a rise in people presenting with these recurrent infections, and I would measure their pneumococcal titers, and they tended to be deficient,
Hmm.
much greater than what I'd seen in the past. And that was, and admittedly, we're carrying this study on and continuing to see how that
Hmm.
correlates. But we wanted to get this study out there because what we've seen is, unfortunately, you have a large percentage of the population who are struggling with symptoms. And because long COVID appears to affect so many different organ systems, they present to some specialist for, say they're having chest pain. They'll see a cardiologist who then, diagnoses them and treats them appropriately. But then they follow up with a gastroenterologist for GI issues, and they maybe see a neurologist for the, brain fog and headaches, and they get kind of bounced around, and there's no consistency of saying, is all this tied together? And so that was, one of the goals was, and I don't know that we've completed that goal, but one of the goals was, could this be a potential cause for all of it? And
Hmm.
so, if that is what long COVID is, you know, how does how do these patients stack up, post-infection, post-vaccination? Because, on one side, the point of the COVID vaccine, like any vaccine, should be improving your adaptive immune response, right? So that you boost your adaptive immune response, you produce antibodies so that with subsequent infection, you have a more rapid and active adaptive response to prevent more severe illness. That's kind of the idea there. Um, but so should prior infection. And so, if you've had a prior infection, whether you're vaccinated or not, you should have an adaptive immune response. That's how we're designed by God. And our immune system is beautiful, and it's mobile. It's constantly evolving. You're making antibodies, you're making things to protect you. And so, the idea was, okay, well, a good control group should be unvaccinated because that's measuring your normal adaptive response versus, you know those excuse me, unvaccinated should be the control group because you're measuring their natural immune response versus vaccinated. Is there a difference, and does that correlate to COVID? And so that was really the idea behind this study. Not that I cared one way or the other on vaccine or not, but it was more, we have people presenting with problems. Is there a way to measure this? Is there
Yeah.
something tangible that they can go to their doctor, go to their primary care and get this lab done if they feel like this is a potential cause that their symptoms onset post COVID?
Right, right. So what we're talking about in research is, we don't want to have biases that you care one way or the other about a
Right.
vaccine, but we want what's called an analytic framework, and that's just how this is set up. We're going to take a break for our sponsors right now. We're going to be back. We were listening to Dr. Henry P. Barnum. He's an otolaryngologist, but importantly, he's a rhinologist in Baton Rouge, Louisiana. He's an LSU Tiger through and through. I got to tell you what, LSU really handed it to Baylor last year in the bowl game. I'm a Baylor Bear, many of you know. But let's take a break here, and we're going to return on the backside of the McCullough Report. Let's get real. Let's get loud on America Out Loud Talk Radio. This is the McCullough Report and Focal Points Substack. Pause right here. Let's get real. Let's get loud on America Out Loud Talk Radio. This is a McCullough Report and Focal Point Substack. I'm Dr. Peter McCullough, your host, and we are having the most fascinating conversation about the nose with someone who's following his nose on this whole topic of SARS-CoV-2, the pandemic, vaccination, and now he's actually measured blood samples in patients with who have long COVID symptoms, and some were vaccinated, some were not. Let's get into the paper in terms of its sample size and what was done.
Right. So basically, what we did was, um, took, once we started this study, was taking the next 100 patients, so the first 100 patients presenting for symptoms of long COVID,
Mm-hmm.
and a couple important points here. So patients were excluded from this assessment if they, number one, had COVID. So recently with a positive test. So by definition, long COVID has to be greater than 3 months of the symptoms. And
Mhm.
so if they had evidence of prior infection or even symptoms concerning for prior infection within the 3 months leading into, they were excluded. Also, subjects who were immunocompromised, whether it be through
Mhm.
medications or a prior diagnosis of immunocompromised status, they were excluded because we wanted more of an equal set to be able to measure the responses. And so basically, we had 100 total patients. So it ended up, pretty consistent with just global vaccination rates, or at least in America. So we had about 81% of the 100 were vaccinated,
Mhm.
and 19% were unvaccinated. It was a pretty equal male and female, so around, just over 50 male and just under 50 female. Um, Basically, they had to, to be included, they had to report that, the vaccinated group or everyone had at least at some point had prior infection with COVID, which is expected at this point, 5 years later. Um, Important that the post-vaccination participants reported onset of chronic symptoms following vaccination and not infection. And so we did
Mm.
want to isolate that out to be able to control for that. They had to all report no prior history. So it's not like they could have had any of these symptoms before and it's like, oh, I'm blaming it on COVID now. So any prior diagnosis, through electronic medical records, questionnaires, they were excluded. And so, we validated who had actually been vaccinated through electronic medical records. Typically, they were completed their primary series at a minimum based on WHO recommendations. Most of them up to 48 months prior to inclusion, and that's an important point because, as we talked about, on one hand, this paper would suggest that the vaccine is doing what it's supposed to do. You're producing an appropriate antibody response or a strong antibody response, and that's the point of an mRNA vaccination. Um, but basically, 48 months prior to, some of them did have boosters, but the question becomes, what's normal? What is too much and how long is too long? And I don't know that we have the answer to that for sure. I think that more studies need to be done, but that's why we did have the control group of unvaccinated, because the closest comparison in my mind was, a natural immune response, which should be an adaptive immune response with production of antibodies. And so we basically, measured SARS-CoV-2 semi-quantitative spike antibody through LabCorp. The reference range on that is zero point 0.8. And admittedly, I would, as we just said, I wouldn't expect anyone to be zero point 0.8 or to be, zero, because if you've had COVID or if you've had the vaccine, that's an appropriate response, is to mount an adaptive immune response and to produce antibodies. Um, but basically, when you compare the two groups, and I see that you have the paper up, in the vaccinated cohort, the average was
Mm.
11,357,
Mhm.
range being 12,000 or 1,291 up to, the lab only goes up to 25,000, and so we did have a lot of results that basically just say greater than 25,000. That's a tough one because you don't know how high it is, and if we, some of the future studies that we're doing right now is continuing to measure these, and if they are coming down, you can't really measure. For instance, like if someone 35,000 and they come down to 26,000, well, that's a significant decrease in that level, but the lab is, both of those two labs are just going to show greater than
Mhm.
25,000, so it's not that helpful. And that's versus the unvaccinated group, which was 1,632. In that group. And so, you know, admittedly, these patients were all presenting for symptoms of long COVID, and they presented for, the most common symptoms that we saw. As I said, it's a little bit of a bias there in that my practice is ENT related or rhinology related, but headaches, brain fog, fatigue, a lot of sleep irregularity. I was seeing a fair bit of like nasopharyngitis, like almost lymphoid hyperplasia in the nasopharynx where the adenoid pad
Mhm.
is, which you often will see in upper respiratory viruses, but it seemed like it was sustained. You
Mhm.
also can see it in immunocompromised state, HIV, and I don't want to necessarily link that to this, but there are reports of lymphoid hyperplasia in those problems, and so we were seeing lymphadenopathy, shortness of breath, kind of the most common things that we were seeing people for, in addition to just sinusitis, which is a lot of times where I see patients in the first place in my clinic.
Yeah. Let me ask you while you're kind of coming up for air there.
Sure.
What percent of the vaccinated were unmeasurably high, greater than 25,000?
I'll certainly get you that information, and you can share it. I don't want to speak without have it in front of me.
Okay,
Um, I
but
will say it was only in that group. So I did put the range on here where basically the range in the vaccinated group was 1,200, to greater than 25,000. The range on the unvaccinated was as low as 1.5 to 4,600. So the highest in the unvaccinated group was 4,600.
4,600. So in the vaccinated group, when you had somebody greater than 25,000, did you just truncate it and say it's 25,000 for analysis?
Four numbers, yes, sir. And that
Okay.
that is a problem, and that's why, admittedly, I would love it if LabCorp, maybe a plug to them, if they could raise their ceiling, that would be wonderful. Because I'd love to analyze that data because we don't know. I don't. The, I mean, just based on these, the speculation is that they, are in the teens or thousands, but I don't know that because we did have a large number that were greater than
Well, I
25,000.
can tell you, I've measured this now probably in a couple thousand patients, so I have a lot of experience with this test. And my experience is, and my patients usually have cardiovascular, so they have myocarditis or thrombosis. Is probably about 5% are unmeasurably high, greater than 25,000.
Yeah.
That what I see in my practice is nearly identical to this. Of interest, we've sent some samples to the Emodia lab in Germany, where
Okay.
they can actually do an ELISA assay to actually measure spike in the bloodstream. Okay,
Okay.
and now it may not be the most sensitive ELISA, but it's been my experience is if the antibodies are less than 5,000, uh, probably will not find spike in the bloodstream. It's just
Okay.
simply a residual antibody response. Greater than 5,000, we have determined to see spike in the bloodstream. The other interesting thing the Modia lab is finding is because they can assess for DNA and RNA, they're definitely finding Pfizer Moderna RNA in the human body years after taking the shot. They're finding
Sure.
it in skin, blood, and white blood cells, but they're also finding DNA fragments. And we've heard about DNA fragments coding for SV40 and the origin of an insertion, the enhancer, promoter, and antibiotic resistant genes. But she said, don't forget the plasmids inside E. coli. Not only do they have the codes that are ramping up production of RNA, but the plasmid DNA is coding for RNA. That's how you make so much of it to make Pfizer Moderna. And so they actually have little DNA fragments coding for little spike fragments. So it breaks off. So what is theorized here is not only do we have the full length spike produced by Pfizer and Moderna, but we actually have a little sprinkling of spike fragments from these little fragments of DNA coding for it.
Which could cause a more responsive adaptive immune system and thereby
Yeah,
increasing the numbers here.
it could, or it could,
Yeah.
it also could promote autoimmunity. So what I've seen here is consistent with my practice. And so I can give you just some anecdotes. Um, there are patients who've taken the vaccine who are perfectly fine. And
Agreed.
right, so the how bad is my batch analysis? We've looked at Pfizer, for instance. 75% of the batches have zero deaths, zero vaccine. I mean, they look very safe, 75%. So I was curious about my mother-in-law who lives with us. She's 92, and she took 2 Pfizer shots in 2021, no symptoms. She said she didn't even feel it in the arm, nothing.
Okay.
So I've been following her carefully. My wife and I didn't take the vaccines, but I've been following her carefully. I said, listen, I'm dying of curiosity. I gotta check mama's antibodies level. So we check her antibody level. She's taking the vaccine, and you know what? She's 200.
Okay. That's I don't know what to make of that.
Yeah, but so it's very, very low. And yet I'll have the next patient. I saw a young medical student yesterday who's had horrible myocarditis. I mean, hospitalized, heart damage, everything. And he's about 7,700 on the antibodies.
Okay. Did your mother-in-law have COVID confirmed?
Not confirmed.
Okay.
So the point is the antibodies, what I'm finding in my practice, and I think probably you would concur, they do provide, they are revealing in terms potentially of not only the interpretation. Remember, tests can have 4 indications. One can be for screening and detection,
Yep.
diagnosis, prognosis, and management. I'm finding that probably prognosis and management they're falling into, and it's affordable test and it's available. But keep going. You
Right.
found more, so
Yeah, no, I mean, you bring up some great questions because we, I mean, obviously, our subset or this study is only representative of the people who are having problems.
right.
We did not measure people off the street, who are not having issues. And so I do think that certainly, more work needs to be done. Because no matter what it's from, there are a set of patients who are struggling. I think that no one would deny that, on either side. And then the question is, what is the hypothesis? What is this coming from? Is it, the increased circulation of spike protein from COVID? I'm not saying from vaccine, but from COVID itself, either isolated as you're talking about, with the test in Germany versus immune complex deposition into various organ systems, driving the diagnosis of long COVID with multiple organ systems. But that could certainly explain, the deposition of these immune complexes into organ
Well,
systems could
well,
explain some of the
right. So
multi-organ problems.
let's just take the virus itself. Forget the vaccine.
Yeah,
So Bruce Patterson, in his analysis in CellDX, he finds the very tip of the spike protein stuck inside white blood cells called the S1 segment.
right.
Okay, that's just the infection itself. But he's found that in 2020, he found that could last for a year and a half. That's as long
Yeah,
as it looked. Okay. Now, recently, there was a paper in a pediatric journal of gastroenterology where, as I recall, it was about 5 months after the infection with the virus, no vaccine, and there was sampling of the GI epithelium, and they found the virus, the intact virus replicating months
okay.
after the infection. Okay. And then the other citation is the autopsy study by the NIH. The senior author is Chertow. So people who had COVID, who got sick and ultimately died within a year, they did autopsies and they found the virus everywhere in the body, in the skin, the hair, the organs, and it was alive and replicating at a low level. Okay, so no vaccine. So
Yeah,
the tip of the spike protein for sure. Patterson showed this. Several studies suggest this virus is in us far longer than what we think. We may be contagious for a week or 2 weeks, but this virus can hang on a lot longer, and these are the sources of data. Recently, I interviewed Dr. Roberto Zabalos on this show, and he suggested that maybe the GI tract is a reservoir. Now, remember, we always have oral nasal secretions and we swallow it.
yeah.
So, I mean, isn't it fascinating that that could be the case?
It really is. I mean, that as I think unfortunately given away, I love this stuff. I love the research. I love the nose, the respiratory tract. I think the beauty of this paper And this paper, in my mind, leaves a lot to be desired. It's going to bring up a lot of questions, but that's the point of doing research, is that
Mhm.
we have to be able to better understand these conditions to improve research for both diagnosis and therapeutic, as you had mentioned earlier.
Mhm.
But in my mind, the beauty of this study is how simplistic it is, in that I don't want to have a narrative. Like I believe in science, and I believe data tells the truth. And
Mhm.
so, I don't I didn't care what people were presenting, like what their background in terms of prior infection or COVID. I just want the data so we can analyze and then move forward and find better options for these people, because there are so many people that are struggling. Obviously, the figure in this is telling. There's going to be a lot of narrative around that, but I didn't intend it for that way. Obviously, the data is the data.
Right.
Um,
Well, listen,
but
it's just, actually, it's funny you mention that, because in the preprint server, what I teach, my colleagues, is that it hasn't been peer reviewed.
yep,
So the rules on the preprint server is we simply have the data, because the data
yep,
are almost certainly not going to change. The interpretation is open. It's your interpretation, my interpretation, whoever
yep.
reads it. So there really is no narrative here. But it is noticeable that those who've taken the vaccine have a much higher measured antibody level, substantially higher. And if that reflects a massive spike protein exposure to the body, or even residual spike protein, if that's what it implies, we've got a problem on our hands, because it's now been years. I imagine some of these people, it was years since they took the shots.
It's 48 months was the longest, but most of them were 48 to 36 months.
Yeah, I mean that's a long time.
Right.
We know with so many infections, the antibody titers come right down. Now, they can be
Yeah.
re-stimulated. With SARS-1, the antibodies came down, and 20 years later, the plasma cells can quickly recognize the antigen and
But
reproduce
that
that.
that that's the beauty of the adaptive immune system. That's why we have it, is
Right,
you have memory immunity to mount a faster response. And
right.
and to your point, like, this is a snapshot in time, and so it's, we intentionally excluded people who had had a recent infection or within 3 months, because obviously the assumption there is it's going to bump your numbers, like they should come up. That's
Mhm.
an appropriate response, but that's why we wanted to just standardize it. Both groups couldn't have had, could not have infection within 3 months, couldn't be immunocompromised, and one snapshot, how does it measure up, and does that correlate with their symptoms?
Wow, wow. What other points do you have for us in this paper?
No, I mean, I appreciate you and everyone who, is getting this information out there, not just mine. I mean, there's a lot of great researchers who are doing great work, and I think that, over the next several months, I think that we're going to see great, things come out. That's the hope, is that, we continue to push and to find more answers, and then develop plans, both diagnostically and therapeutically, for these
Mhm.
people, because, unfortunately, I wouldn't be surprised if we see another, some pandemic or some weird virus in our lifetime. I hope that that's not the case, but part of doing all of this is so that we better understand, and that's what I mean by the beauty of doing research on a novel virus. Is it's something that is just such a fascinating area of research, because there's so many unanswered questions, and that's, I think, tip my hat to everyone who's doing research in this, both doctors and patients and scientists. Not just in the medical community, it's people who are out, looking for answers on their own, and they're presenting it to their physicians and saying, hey, can you help me understand this? That's important, and I get that all the time, because management options, that, that's something that continues to be need to be explored. I know that you certainly have, and have a lot of great data out there on options available for people, but all of this should continue to evolve. Like that's our goal.
It certainly is. I felt compelled to try to offer something to patients based on the best available evidence, signals of benefit, acceptable safety. That's how we've come up with this McCullough protocol-based spike protein detoxification with nattokinase, bromelain, and curcumin. We've reached out to Dr. Shirasawa in Japan. He additionally uses papain, lumbrokinase, sereptase. The idea of an enzymatic approach for residual spike protein, inferring that the spike protein is still in the body. Now this Emodia lab coming on, as well as there's a paper from Yale and another one from Boros, all showing the spike protein is physically in the bloodstream long after vaccination. It's physically there, actually trimerized. So in terms of what does this mean, based on where we are right now, Dr. Barnum, I think this means probably continued spike protein presentation to the immune system. And that
I think you're right.
Yeah. But this is great work. It's helped us advance. One of your colleagues, Mary Telly Bowden, has always said, I think that the antibodies in the vaccinated are about 10 times higher than the unvaccinated.
Certainly where the data stacked up.
Yeah, that's a pretty good dead reckoning. That's what I found. It's a great conversation. We're going to have to leave it here. I want to thank you so much for presenting your paper on the program.
Thank you so much for having me.
Let's get real. Let's get loud on America Out Loud Talk Radio. This is McCullough Report and Focal Points Substack.